You may begin, Dr. Ishimori.
Okay. Good morning. Welcome to the virtual rheumatology practicum for Monday morning. This is our webinar series. We have a few housekeeping items that I want to discuss. But first, I'm going to introduce myself. My name is Mariko Ishimori. I'm the Fellowship Program Director at Cedars-Sinai Medical Center. I'll be moderating this session with Saurav Suman, who's a second-year fellow at the University of Kentucky. We ask that all of the attendees are muted throughout the webinar. Please send any questions or comments that you might have for the presenter. There are 3 different ways and options that you can send your comments or questions. One is using the chat function for general comments that everyone can see. You may also use the raise your hand function to notify us that you need attention, and we can send a private chat in response. And the Q&A is also used to post questions relevant to the lecture. These questions can only be seen by the lecturer and the team moderating as well. Any other issues, you're also free to email our team. So I'd also like to introduce our co-fellow, Saurav Suman, who will be introducing our speaker today, Dr. Brad Rovin.
Good morning, everyone. So my name is Saurav Suman. I'm a second-year rheumatology fellow at University of Kentucky. So Dr. Brad H. Rovin is the Lee A. Hebert Professor of Nephrology. He received his Bachelor of Science in Chemical Engineering from Northwestern University in Evanston, Illinois, and his Doctor of Medicine from University of Illinois School in Chicago. He completed a residency in internal medicine at Barnes Hospital in St. Louis, Missouri, and a fellowship in nephrology at Washington University School of Medicine, St. Louis. He joined the College of Medicine faculty in 1990, became director of the Division of Nephrology in 2004, and served as vice chairman of medicine for research from 2009 to 2019. In 2019, he became the medical director of the Ohio State University Clinical Research Management Institute. Dr. Rovin has had several leadership roles in the American Society of Nephrology. Most recently, he was appointed deputy editor of Kidney International, the flagship journal of International Society of Nephrology. Dr. Rovin studies the immunopathogenesis of glomerular and autoimmune diseases. He is heavily involved in clinical trial development and design for investigator-initiated and industry-sponsored trials. He is a founding member of NephroNet, a grassroots nephrology community clinical trial organization, and the Lupus Nephritis Clinical Trials Network. He is and has been the principal investigator on several trials of novel therapeutics for glomerular diseases. With this, I would like to hand it over to Dr. Rovin, who will talk to us today about lupus nephritis.
Okay, great. Thank you very much for having me at your series, and I appreciate the introduction. So I'm going to talk to you about the management of lupus nephritis, and I put 2021 so that we talk about some of the newer developments that have come down the pike in the last year to 2. These are my disclosures. So the objectives of this lecture are to review the general management for lupus patients suspected of having kidney involvement, look at current options for induction therapy, and review current options for maintenance therapy, and highlight novel therapies being tested for lupus nephritis. So just to get everyone on the same page, look at the prevalence of kidney abnormalities in patients with lupus nephritis. And you can see that proteinuria is present in 100% of the patients. And of course, that's because we define lupus nephritis as patients who have proteinuria. If you actually look at patients with low-grade proteinuria, and I'll show you some data in just a minute, patients with very little proteinuria can still have significant lupus nephritis. The other thing that really is striking is that most of the patients will have microscopic hematuria. And I put this impaired kidney function, 40 to 80% of the patients with lupus nephritis I would suggest that the majority of patients have some kidney dysfunction when they're first diagnosed. This is very difficult to detect simply by looking at the serum creatinine in these young patients because we don't often know their baseline serum creatinine. But in many cases, if you do know the baseline, you'll see that there is some elevation in the serum creatinine suggesting impaired kidney function. Now, one of the most important things we can talk about in terms of lupus nephritis management and diagnosis is how to assess proteinuria. And of course, in the old days, all we really had was the dipstick. And in fact, in the original ACR recommendations, dipstick proteinuria was used to guide the management of lupus nephritis. The nephrology community has been very supportive of the random spot urine protein to creatinine ratio. And this has probably been adopted by most subspecialties as the way to look at proteinuria. And I've got this in red here because, in our opinion, it's really not a very good measure of proteinuria. It's highly variable and highly inaccurate because the amount of protein that one excretes changes over the course of the day. We did a study several years ago from our group. We looked at spot protein to creatinine ratio and then compared it in the same patient to the 24-hour protein to creatinine ratio, and then plotted this against the 24-hour protein to creatinine ratio. If the spot urine protein creatinine ratio accurately reflected the 24-hour protein to creatinine ratio, all of these individual patients would line up very close to the line 1 or unity. And as you can see, this is not true. And in fact, the dispersion is more in the lower levels of proteinuria than when you get out to very high levels of proteinuria. But this is generally the range of urine protein that we see in the majority of our patients with lupus nephritis. Of course, patients with class 5 or membranous lupus nephritis can have nephrotic range proteinuria. 24-hour urine assessment is also a possibility, but we recommend using the 24-hour protein to creatinine ratio just to account for incomplete collection of the 24-hour urine. Kidney function is most easily assessed in patients with lupus nephritis by serial measurement of the serum creatinine. It's important to understand that serum creatinine may be increased or decreased by conditions that are completely independent of the glomerular filtration rate. So, tubular secretion of creatinine can be increased by certain drugs, for example, trimethoprim, when you do this, this is decreased by trimethoprim, the serum creatinine can increase. And of course, in a lot of patients treated with immunosuppressive medications, they're on sulfa drugs, including a trimethoprim component. So please keep that in mind. Tubular secretion is actually increased in patients who are hypoalbuminemic. And so patients who have a lot of proteinuria may actually have a decrease in their serum creatinine because of the low serum albumin. This I highlighted in red because it's important and relevant to almost all of our patients. High-dose steroids, which we usually give at the beginning of therapy for a patient with lupus nephritis, can affect skeletal muscle metabolism and can increase serum creatinine. And finally, a patient's diet is important as well. A diet high in cooked meats can increase the serum creatinine, and a vegetarian diet can decrease the serum creatinine. So all of us moved on to using estimated glomerular filtration rate. All of your laboratories have that. And these are determined from estimating equations that were designed in populations that were not typical of a lupus population. So that's problem number 1. Number 2, the most important variable in all of the estimating equations is the serum creatinine. So all the weaknesses of serum creatinine measurement that I just talked to you about still apply to the GFR equations. And finally, all of the glomerular filtration rate equations that we use today consider patients of the same age, race, sex, and serum creatinine have the same rate of creatinine production, and we know that's not accurate. So the nephrology community continues to look at ways to measure GFR more easily than actually doing inulin clearance, which is done very infrequently these days. I want to start out with a provocative case simply to get you thinking about the utility of a kidney biopsy, because that also has been controversial in some cases. So this is a 61-year-old Caucasian woman with a diagnosis of lupus. Diagnosis was established 2 years ago. The patient presented with rash, pleurisy, synovitis, and a positive ANA. She was currently found to have a serum creatinine of 3.8. Previously it had been normal. She has proteinuria that's under 3 grams a day, but still substantial, and she has microscopic hematuria. Her C3 was low, C4 was at the low end of normal. Anti-double-stranded DNA antibodies were positive, and she had developed a low ejection fraction and had some schistocytes on peripheral smear. So the question to you all is, what should we do next? A kidney biopsy to determine what's going on in the kidneys, begin treatment with high-dose steroids or cyclophosphamide, start dialysis, or give inotropes to improve cardiac function and thereby kidney function. Well, I didn't do polling questions, but the correct answer for this is A. We really don't know what's going on in this patient's kidney. We know that she has had a rapid decline in her kidney function, and most likely that would be considered to be due to lupus nephritis. She has no indication for dialysis, and she may or may not give inotropes, but that's probably not what's going on only in this situation, accounting for her impaired kidney function. So we actually did a kidney biopsy on this patient, and as you can see, she has fibrin thrombus in an arteriole in the kidney. She has no glomerular capillary hypercellularity, and she has no interstitial inflammation. And in fact, when we did immunofluorescence on this kidney, the patient had no immunoglobulin deposition. So the pathologic diagnosis was thrombotic microangiopathy, no lupus nephritis, and no active inflammation. So the treatment of this patient depended very much on the biopsy result, and using high-dose corticosteroids and an immunosuppressive agent would have been inappropriate. So this brings me to talk about the kidney biopsy and why it's needed in lupus nephritis. So not all kidney diseases in a lupus patient is lupus nephritis. About 5% of lupus patients may have other glomerular diseases. Lupus podocytopathy, which is damage to the foot processes of the podocyte, may coexist with lupus nephritis in about 1.3% of the cases. This is treated differently than active lupus nephritis, mostly with corticosteroids, because it often resembles minimal change disease in our patients. Antiphospholipid antibody syndrome nephropathy, with or without lupus nephritis, can occur in up to 24% of lupus nephritis cases. And interstitial nephritis can occur. It's fairly rare in the absence of the glomerulonephritis, but it does happen. Additionally, not all kidney disease in lupus nephritis needs to be treated aggressively with immunosuppression. Class 2 lupus nephritis, for example, can be treated simply with the medications you're using to treat non-renal lupus, and chronic changes with little active inflammation do not need immunosuppressive therapy. So in terms of doing a kidney biopsy, a question that often comes up is, should there be a proteinuria threshold for the kidney biopsy? And most often, we consider doing a kidney biopsy in patients who have more than 500 milligrams of protein a day. In some centers, it's more than 1 gram of protein a day. But when we look at patients who have had kidney biopsies with less proteinuria, And this is from one of our own studies, but there are several studies in the literature. These are patients who had proteinuria less than 500 milligrams a day. You can see what the proteinuria is here compared to a cohort from the same center with proteinuria. Serum creatinine was no different. In other words, the patients had a normal serum creatinine. But if you go down to see the histologic results, you can see that about 30% of these patients had class 3 lupus nephritis, and 46% of the patients had class 4. And the activity index was not necessarily quite as high as those patients with a higher degree of proteinuria, but it was still substantial at 6, suggesting that even patients with low-level proteinuria can have significant renal lupus nephritis. This is the overall treatment strategy in lupus nephritis that I think serves as a good starting point for consideration of therapies. Induction therapy starts when lupus nephritis is diagnosed, and it's generally given for the first 3 to 6 months, and then patients are assessed to understand if they're stable, better, or if they've achieved a complete response or a partial response. If during induction therapy the patient gets worse, then one should consider an alternative induction therapy. And we'll go over these in just a minute, but the two main induction therapies are mycophenolate and cyclophosphamide currently. If the patient then responds, they can go into a maintenance phase of treatment. If the patient, after an alternative induction therapy, does not respond or they get worse, they can be considered refractory, and they'll have to be considered for salvage therapy. We're not going to discuss this today. There's no real good answer for this question. Maintenance therapy is generally then given for a prolonged period of time, and usually within the first 2 years, patients will develop a complete response or a partial response. And then it's not entirely clear what to do with therapy. You can consider tapering therapy if the patient has received at least 24 months of maintenance and 12 months, and they've been for a year in complete remission. For patients who are partial responders, it's not clear whether or not therapy has to be considered indefinitely. This sort of question leads to the recommendation or consideration of doing a repeat kidney biopsy for these patients to assess what's actually going on in the kidney and decide whether or not therapy should be continued or can be tapered off. I wanted to talk a little bit about the evolution of therapies for lupus nephritis. In the kidney community, our guidelines are called the KDIGO guidelines, and in 2012 we did the first kidney KDIGO guidelines for glomerular disease, and lupus nephritis was part of that publication. And at that time we used high dose IV methylprednisolone for up to 3 days, followed by oral prednisone, 1 milligram per kilogram body weight. And to that was added cyclophosphamide high dose, which is the NIH regimen, oral cyclophosphamide, intravenous cyclophosphamide called urolupus regimen, or low dose cyclophosphamide, or oral mycophenolate. Now fast forward almost a decade, and you can see that there's been updates to the guidelines. The KDIGO guidelines will actually come out in 2021, and what we've done is start out again with methylprednisolone, but this is limited to about 1 gram instead of up to 3 grams. Oral prednisone starts out at a lower dose and is tapered more quickly. And then we're recommending low-dose urolupus cyclophosphamide for initial treatment, or mycophenolate 2 to 3 grams a day for 6 months. Similarly, guidelines came out from the European kidney community in 2019, essentially very similar, methylprednisolone up to 2.5 grams total. They suggest an even lower oral prednisone dose, and then they recommend urolupus cyclophosphamide, mycophenolate, as the KDIGO guidelines did, and they've also adopted mycophenolate in a lower dose plus a calcineurin inhibitor, the so-called multi-target therapy that has been mostly studied in Asia. So a few little hints to choose between cyclophosphamide and mycophenolate. If you believe a patient may have difficulty adhering to an oral regimen, one should consider intravenous cyclophosphamide. And we do this, again, using the low-dose cyclophosphamide. In severe, rapidly progressive lupus nephritis, where the creatinine is deteriorating very quickly, the biopsy of these patients often shows severe crescentic glomerulonephritis. One should consider high-dose cyclophosphamide. In terms of fertility issues, premature ovarian failure is both cyclophosphamide dose and age dependent, and ovarian protection should be considered. These data are from patients treated with cyclophosphamide. I believe these were actually patients with ANCA vasculitis. Nonetheless, this is the cumulative dose of cyclophosphamide relative to age that are required to cause a 50% incidence of ovarian failure. And as you can see, in patients in their 20s, you need about 20 grams of cyclophosphamide. In the 30s and 40s, you need much less cyclophosphamide to impair fertility. So this should be kept in mind when you're deciding on treatment for individual patients. And finally, very publicly acknowledged that mycophenolate is considered to be superior in Black patients with lupus nephritis. This conclusion actually came from this article published in 2009, and here are the actual data comparing mycophenolate and cyclophosphamide. And as you can see, in a post hoc analysis, there was really no significant difference in mycophenolate or cyclophosphamide in Black patients. There was a difference in patients, Black patients and other patients of mixed race or Hispanics in the original study, and this has been interpreted as that mycophenolate is superior in Black patients. I don't think this is correct. We treat many of our African origin patients with cyclophosphamide to good end. So again, it's a very individual decision in terms of which therapy you choose first. In terms of maintenance therapy for lupus nephritis, both the new KDIGO guidelines and the updated 2019 European guidelines suggest decreasing the dose of steroids, and then mycophenolate is the first choice for most patients. Azathioprine can be used in patients where pregnancy might be contemplated, or in patients who don't tolerate mycophenolate because of gastrointestinal distress is usually the main reason. In terms of choosing between mycophenolate and azathioprine, the two main studies that helped us determine that these were both reasonable therapies for maintenance were the MAINTAIN trial and the ALMS maintenance trial. The MAINTAIN trial was a study conducted after low-dose cyclophosphamide, mainly in patients who were Caucasian. This looked at a renal flare endpoint. And as you can see, there was really no difference over 5 years in terms of the renal flare endpoint for mycophenolate or azathioprine. This is often compared to the results of the ALMS maintenance trial, which looked at mycophenolate and azathioprine after either cyclophosphamide or mycophenolate as the induction therapy. These trials really are not comparable. The ALMS maintenance trial was larger, it was blinded, and it was actually multi-ethnic, multiracial. It also had a composite endpoint, but you can see here that in this trial, patients did much better with mycophenolate than they did with azathioprine. And if you break out the components of the composite endpoint, you can see there were fewer treatment failures with mycophenolate. There was almost no end-stage kidney disease. There were fewer flares. There was less need for rescue medication and doubling of serum creatinine. A doubling of serum creatinine is a surrogate which portends end-stage kidney disease in the future. So overall, for most, but even despite that, as you can see, the difference here is rather small. So for most patients, mycophenolate or mycophenolic acid would be the maintenance drug of choice. However, azathioprine is not a bad alternative, and as I said, can be considered in specific cases when mycophenolate is not appropriate. So one of the questions you might ask is, how are we doing with the recommended regimens by the guideline makers? And these are basically urolupus, cyclophosphamide, and mycophenolate. And so I pulled all of the data from the standard of care arms. So none of these data include experimental medications. The standard of care arm from several recent trials. The drugs are either mycophenolate or low-dose cyclophosphamide. I did throw high-dose cyclophosphamide in for comparison. And you can see here that really the complete renal response rate at 1 year varies from about 30% to as high as 54%. But if you average these, the 1 year complete response rate using mycophenolate is about 35% of the patients, and using intravenous cyclophosphamide, low dose in particular, is about 34% of the patients. So no particular difference, and not a very good complete response rate after a year of therapy. And in terms of the most important thing to consider for therapy in lupus nephritis patients is preventing end-stage kidney disease necessitating a kidney transplant or dialysis. And as you can see here, this is a epidemiologic plot looking at 5, 10, and 15-year outcomes in developed countries. This is the decline in end-stage kidney disease from the mid-1970s up until about a decade ago. And you can see that at any given length or duration of follow-up, you can see that there's been a decline in end-stage kidney disease. In the 2000s, this seemed to plateau, and then it seemed to increase during the mid-2000s, the first decade of the 2000s, and then sort of has plateaued again. But as you can see here, we have not improved further beyond this plateau in terms of preventing end-stage kidney disease. And about 20% of patients with lupus nephritis, especially proliferative lupus nephritis, will develop end-stage kidney disease over time. So I think we can do better. And this is a sampling of recent successful lupus nephritis clinical trials suggesting that we can do better. We'll go over each of these in detail, but to introduce you to these medications, this is obinutuzumab. It's a monoclonal antibody that targets CD20, so it's like rituximab in many ways. The phase 2 trial is done. This was a positive result showing more responses to the rituximab or to the obinutuzumab group than the standard of care group, placebo group. Phase 3 is enrolling. The belimumab trial is complete. depleted. This was called Bliss-LN. This is a monoclonal antibody against the B cell growth factor, Bliss or BAFF. This phase 3 trial is done, a positive result, and this is actually now approved by both the FDA and the European Society for use in lupus nephritis. Voclosporin is a small molecule. It's a calcineurin inhibitor that affects T cells. The phase 3 trial is done, a positive result. This has also recently been published, and it has been approved by the FDA for lupus nephritis, and approval by the European regulatory agency is in progress. So looking at B-cell targeted therapies to start with, we of course all know about rituximab, an anti-CD20 that has direct cytotoxic effects on the B cell. Ocrelizumab similarly, and obinutuzumab affects the B cell as well. You can have inhibitors like belimumab of soluble BAFF, and there's a whole variety listed here. And then also inhibitors of membrane-bound BAFF. In addition, we have drugs that affect the plasmablast, and this includes atacicept, and maybe to some extent ocrelizumab and rituximab. And then drugs that directly affect the plasma cell, such as proteasome inhibitors. Rituximab was tested in a large randomized controlled trial called the LUNAR trial, and this failed. And I put this sort of here to be provocative. Did it really fail, or did we do the trial design incorrectly? Here are the data from the primary publication showing that there was no difference in patients where rituximab was added on to mycophenolate or placebo was added on, either for complete renal response, partial renal response, and this was the number or percentage of no responders. However, if you look at LUNAR in a post hoc analysis, as we did, from the perspective of B cell depletion, you can see that the complete renal response rate increased at week 52 and week 78 significantly in patients who had complete peripheral depletion of B cells, as opposed to patients who had incomplete peripheral B cell depletion. Why is that relevant? Well, it turns out that at least in lupus nephritis, peripheral B cell depletion is not very good. And this was one of the reasons obinutuzumab was trialed in lupus nephritis. If you compare obinutuzumab plus mycophenolate versus rituximab plus mycophenolate, these are data from the LUNAR trial, these are data from the Nobility trial, so they were not done at the same time in the same population, but very similar lupus nephritis populations. Looking at the percent decrease in CD19 counts, less than 5 cells per microliter by flow cytometry, you can see that with obinutuzumab, by week 2, almost everybody has complete B cell depletion, and this is sustained throughout the year. In the LUNAR trial, you can see that by week 2, about half the patients have complete B cell depletion. It's up to 3/4 by week 4, and close to 90% by week 12, and it's not sustained throughout the entire 1 year. This suggests that a drug that maybe like obinutuzumab has a higher increase in cytotoxicity to deplete B cells would be effective in lupus nephritis. So the Nobility trial was a phase 2 trial. It was comparing obinutuzumab, 1 gram and 1 gram given at weeks 1 and 2, and then repeated at week 24 and 26. And the trial was continued for 2 years. This was compared to placebo. All patients had mycophenolate as background therapy, and all patients received corticosteroids, 1 gram of methylprednisolone, and a prednisone taper, starting out with modest dose of prednisone. These were the outcomes. The complete renal response rate at week 52 showed 35% versus 23% in placebo, not quite reaching statistical significance. By week 76, 40% versus 18% in the placebo group. This did reach statistical significance, and this actually was maintained through 104 weeks. At the end of week 76, or a year and a half, you can see that the patients in the obinutuzumab and placebo groups had very similar rates of any adverse events. There was only 1 death compared to 4 deaths in the placebo group. Serious adverse events were slightly higher in the placebo group, and serious infections were higher in the placebo group, suggesting that the addition of obinutuzumab to standard of care therapy did not increase adverse outcomes. Now, talking about belimumab, this is a design of the BLISS-LN trial. The BLISS-LN trial took patients with active lupus nephritis, and this was a very interesting trial because even though patients were randomized 1-to-1 to receive placebo or belimumab for 2 years, what you can see here is that the principal investigator at each site could decide whether or not the background therapy was high-dose corticosteroids plus mycophenolate or high-dose corticosteroids plus cyclophosphamide. The mycophenolate group was maintained with mycophenolate, and the cyclophosphamide group was maintained with azathioprine. So this duplicated the Eurolupus trial, and this duplicated the ALMS trial, or part of the ALMS trial. Belimumab, as I said, was continued for 2 years. By week 24, steroids had to be 10 milligrams a day or less. At week 52, well, the primary endpoint was week 104. At week 52, there was a key secondary endpoint. The primary endpoint in this trial was also unique. It was called PERR, or Primary Efficacy Renal Response. And the secondary endpoints were complete renal response, time to renal-related event or death, and overall renal response. Now, what is the PERR? This is really a renal response that's a little bit more relaxed than the complete renal response. It's based on data that suggests that if patients achieve a protein to creatinine ratio from a 24-hour urine after a year of therapy that is less than 0.7, less than 0.8, they really have good long-term outcomes in terms of their kidney function in lupus nephritis. So the PERR was defined as urine protein to creatinine ratio of 0.7 or less, GFR that was no more than 20% below the pre-flare value, or greater than 60 ml per minute per meter squared. The complete renal response was pretty traditional. A complete renal response required a urine protein to creatinine ratio of 0.5 or less, a very rigorous GFR metric, less than 10% below the pre-flare value, or greater than 90 ml per minute per 1.73 meters squared. Renal-related events were end-stage kidney disease, doubling of serum creatinine. These events did not happen very often in the BLISS-LN trial, but mainly renal worsening, evidenced by increasing proteinuria or impaired kidney function. So these are the outcomes in the BLISS-LN trial. The time to PERR is shown here, and you can see that, and this is the time to complete renal response. You can see that in the first few months or first few weeks, this increased in the belimumab group, and this remained different than the placebo group throughout the 104 weeks. And you can see the same in the complete renal response. In fact, the curves are really parallel, although there's fewer complete renal responses compared to PERRs because the renal response was more rigorous here. In terms of total renal-related events or death, you can see that there were far fewer renal-related events or renal worsening in the belimumab group compared to the placebo group. There were very few events, as I said before, of end-stage kidney disease or death. Again, the addition of belimumab to the standard of care therapy, so adding a third immunosuppressive drug to the standard of care therapy, did not increase the severity of adverse events. As you can see here, one or more adverse events was the same in both groups. Severe adverse events were about 10% in both groups, and infections of special interest was the same again in both groups. Okay, in talking about calcineurins and lupus nephritis, just to provide a little bit of background, the original multi-target induction regimen was designed and tested in China. This was a rather large population of lupus nephritis patients. All of the patients were given 3 days of methylprednisolone and then started on 0.6 milligram per kilogram per day steroids that were tapered over time. And the patients were randomized to receive a relatively low dose of mycophenolate, 1 gram per day, and a low dose of tacrolimus, which of course is a calcineurin inhibitor, most frequently used in kidney transplantation and solid organ transplantation, or IV NIH level cyclophosphamide. And then the patients were followed for complete renal remission. These are the data from the original trial. And as you can see, if you just focus on the red boxes, 46% of the patients at 6 months had achieved a complete renal response in the multi-target therapy group, compared to the cyclophosphamide group, where only 26% of patients had achieved a complete renal response. This trial did include some repeat kidney biopsies. There were 14 in the multi-target group and 9 in the cyclophosphamide group. As you can see in both groups, the patients had a very high activity index at the initial biopsy, and at the week 24 biopsy, the activity index was reduced considerably in both arms of the study. It was interesting that unexpectedly, the multi-target regimen, which was thought to offer patients less adverse event risk, actually had a higher percentage of patients who had an adverse event, 7.2% versus about 3% in the cyclophosphamide group. But bear in mind, the numbers are small, and this did not reach statistical significance. Interestingly, more patients in the multi-target group than the cyclophosphamide group dropped out as a result of adverse events, about 5.5% versus about 2%. Again, a trend, but not statistically significant. Interestingly, the investigators followed up for an additional 18 months with patients from the original cohort who achieved a complete or partial remission at 6 months. The patients who were in the cyclophosphamide arm were maintained on azathioprine. The patients who were in the multi-target arm continued on mycophenolate. And then all patients were given 10 milligrams a day of steroid. This is the end of the first 6 months, the beginning of the follow-up period. And you can see that the multi-target group has an increased number of complete remissions compared to the cyclophosphamide group. However, very quickly during the follow-up period, the cyclophosphamide patients catch up, and there is no statistical difference in the end between cyclophosphamide and multi-target therapy. So voclosporin is a novel, and I'll discuss why it's novel later on, is a novel calcineurin inhibitor. And this was tested in a phase 2 trial. It was tested in 2 different doses of voclosporin, a low dose and a high dose, again with matched placebo, and a background of 2 grams a day of mycophenolate and oral corticosteroids. What was unique about this particular trial is the forced corticosteroid taper. The patients started out with a very low dose of steroids, 20 to 25 milligram. And as you can see, by 8 weeks, they were tapered down to 5 milligrams a day. And by 16 weeks going forward, 2.5 milligrams a day. So this is both the lowest use of steroids and a very aggressive steroid taper compared to most or all of the pharma-based phase 3 trials. This was also different than the original multi-target, which looked mainly at patients who were, or only at patients who were Asian and mainly Chinese patients. This was a more diverse ethnic and racial cohort. As you can see, there were a small number of African American patients in the trial, around 5% total. Patients from Asia, both South Asia, so patients from India, and also Asian patients, Chinese patients, and then a fair percentage of patients who were Hispanic. The primary endpoint was complete renal response, and in this phase 2 trial, the complete renal response primary endpoint was looked at 24 weeks, but also examined as a secondary endpoint at 48 weeks. And you can see here that the low-dose cyclosporin or voclosporin was significantly different than placebo, both at 24 weeks and at 48 weeks. The high dose was not statistically significant at 24 weeks, but was at 48 weeks. And again, the safety summary caused some concern at the time of this trial. There was only 1 death in the control group and 2 deaths in the high-dose voclosporin group. But in the low-dose voclosporin group, there were 10 deaths. And it was not clear why this was the case. Certainly, it didn't seem dose-dependent, and it probably is related to where the studies were done and whether or not those places had good enough access to healthcare if a patient got sick. But the reality was we had difficulty explaining this other than by chance alone. So a phase 3 trial was conducted. The phase 3 design was very similar to the phase 2 design. We used low-dose voclosporin on the same background of mycophenolate and corticosteroids compared to placebo. The primary endpoint was complete renal response at 52 weeks. And as you can see here, compared to control, there was about a 20% difference in complete renal responses in the voclosporin group. The safety summary is really important to consider here because in this particular trial, we did not see more adverse events in the voclosporin group, and especially looking at deaths, you can see that there was only 1 death in the voclosporin group, suggesting that the phase 2 trial was just by chance that there were more deaths in the low-dose voclosporin group. Now, why would we differentiate, or how can we differentiate voclosporin from the other calcineurin inhibitors? So voclosporin, this is cyclosporin. This chemical formula is cyclosporin, and this is the only modification that creates voclosporin. So you can say, well, that doesn't mean much, but what it translates to is a predictable pharmacokinetic and pharmacodynamic relationship and a linear relationship between level and dosing. So it's much easier to dose than the traditional calcineurin inhibitors, and you may get away without having to use levels. It has about 3 to 4-fold increased potency compared to cyclosporin, and it has an altered metabolic profile. So there's no need for weight-based dosing. Compared to cyclosporin, it has an improved lipid profile. Compared to tacrolimus, which increases the likelihood of developing diabetes, it has a reduced risk of diabetes, and it does not decrease mycophenolic acid levels when used in combination with MMF, which can happen with cyclosporin. So here's a final thought, and then I'll be available to take questions. When we look at all these trials, and I've put the percent complete response rates here that I showed you earlier. These were trials that were largely only modestly successful in the past. And here are the complete response rates in the BLISS trial, the Nobility trial, and the 2 voclosporin trials. You can see that we don't have a substantial increase in the complete response rates compared to what I'm showing you here. Now, there's some issues to take when you think about comparing trials. And the criteria for complete renal response is really different amongst all the trials. And I've listed some of the differences here. You can look at this on the website to spend more time with it. So that these results are not necessarily exactly comparable. But I think we can say that when we look at these results, even though they're encouraging and they suggest that we can do clinical trials and have a drug approved for lupus nephritis, we have more room to go. And there's several trials ongoing now in a whole variety of with a whole variety of biologics with very selected targets in lupus nephritis that will hopefully allow us to improve overall the complete response rate of patients with lupus nephritis, either added to what we consider standard of care now, mycophenolate and cyclophosphamide, or used in combination perhaps with some of the drugs that we've discussed today, or even some of the newer drugs that have not been approved yet. But may succeed. Thank you for your attention. Happy to take some questions.
Thank you, Dr. Rovin. That excellent tour. We've come a long way since nitrogen mustard in the 1950s and lupus nephritis.
Yep.
Yeah. So we do have several questions in our Q&A section. Our first question is, where do the recommendations for the dose of methylprednisolone pulse come from? Most rheumatologists use methylprednisolone 1 gram IV QD times 3 days for everything. I think that's a question that's part of rheumatology lore that does get, wondered.
Yeah, so I'm not entirely sure of the original origin of that dosing of methylprednisolone. In nephrology lore, that actually comes from how we induce patients for kidney transplantation. We found that if you gave 3 grams, patients tolerated it. If you gave more than 3 grams, the incidence of infections, some of which were fatal, was markedly increased. So we gave no more than 3 grams. Is there a justification? And I think that's a really good question. This has been reviewed recently. I think it's been in Frontiers of Immunology by one of my colleagues. And the dose of intravenous methylprednisolone that results in very rapid control of inflammation is probably 1 gram. And beyond 1 gram, you're probably not getting more efficacy, but you may be increasing the side effects. So, and you can look at this based on sort of the pharmacodynamics of corticosteroids. You can also look at this in the practical sense by some trials, by the data from some trials that have been done in lupus nephritis, which is relevant to today's discussion. So if you look at the steroid-free trial called the Rituximab trial that was done in England, 1 gram of methylprednisolone was given along with 2 grams of rituximab, and then patients were started on mycophenolate with no oral corticosteroids. These patients were not compared to a control group, unfortunately, but these patients historically had remission rates, complete and partial remission rates, that were comparable to high-dose steroids. The second evidence that 1 gram is sufficient is if you look at the old ocrelizumab trial and look at the standard of care compared to the ocrelizumab group. And this was actually segregated out into patients who received 500 milligrams, patients who received 1 gram, and patients who received above 1 gram of methylprednisolone. And you can see that the response rate sort of plateaus with 1 gram of IV methylprednisolone. So this is a long-winded way of saying that in our group and in many groups, we are now really giving 1 gram of methylprednisolone or less at the beginning, depending on the severity of the disease. You can make a case, mostly based on tradition and not evidence, of giving more than 1 gram if you have a rapidly progressive lupus nephritis. But you get the most bang for your buck in terms of efficacy and decrease in inflammation that is long-lasting with 1 gram of IV methylprednisolone.
So, Dr. Rovin, we have a question. How do you make a decision on when and how to add new medications such as belimumab or calcineurin inhibitors on the existing regimen for lupus nephritis?
Yeah, that's a great question. So, so there's a lot of things to consider, and I think we should all be, conscious of the cost of these new medications. They're phenomenally expensive, as you know. But they also can provide benefit. So the way I'm thinking about it right now, so we don't have a lot of experience with this outside of the clinical trial. As the drugs are now available and we're going to start ordering them and sort of playing around with them, for lack of a better term, we're going to understand how to use these. But my initial impression of how to use these is as follows. Because in both the voclosporin trial and the BLISS-LN trial, 30% or more of the patients responded to routine standard of care, mycophenolate plus modest dose of steroids. My suggestion is that we start patients with what we know, and then we monitor the patients over the first 3 months of that therapy. There are data to suggest who will do well on that therapy, looking at the reduction in proteinuria at 3 months, as well as the normalization of complement if complements were low to start with. And if you have a 25% or more decline in proteinuria, and you normalize complements, or your complements start to improve, start to increase, those patients, generally speaking, will do well in terms of response using the therapy that you've started them on. If the patient is worse, or the patient has not met those metrics at 3 months, I'm going to say 2 to 3 months, then I would suggest switching to an alternative induction regimen. And that alternative induction regimen these days can include, for example, if you started with cyclophosphamide, you could switch to mycophenolate or vice versa. But you really could say, well, I started with mycophenolate and I'm not getting the response that I had hoped early on, so I want to sort of switch to something new. You could then put that patient on a voclosporin plus mycophenolate regimen. You could do the same thing with belimumab. So I think in my practice, that's how I'm approaching it right now. Now, as we get more experience with this, I think we'll be able to understand better in whom to give these medications. One thing that I think is really important, and I'll just say this because part of our research is biomarkers, is, you know, even though we have these positive results, we did not develop biomarkers of the characteristics of the patients who might be best suited to these new medications. And I think, of course, this is the goal of personalized medicine and what we want to accomplish in the future. So until we have those biomarkers, I think we don't really know. But I think a sensible approach is what I just outlined.
Okay. Thank you so much, Dr. Rovin, for your excellent talk. This concludes the first talk, and we are now going to go ahead and pass on over to the next session, which will be moderated by Dr. Vineet Sandhu, who is at Loma Linda, as well as Ronak Patel.
Thank you very much. Good morning, everybody. And if you're joining us now, just a few reminders. So if you were trying to figure out how you can participate in this discussion and exciting meeting we've got moving forward, use the chat box for general comments. The raise your hand option is to be used if you're having any technical issues. The Q&A is to be used to post questions regarding the lecture content. So it is my pleasure to present to you today Dr. Richard Furie. Dr. Furie is the Chief of the Division of Rheumatology at Northwell Health. He is a rheumatologist whose activities for the last several decades have focused on patient care, physician education, and clinical research in the area of anti-rheumatic drug development. He directs the program in novel therapeutics, the health system's clinical research program in musculoskeletal disease. He also directs the hospital's SLE and Autoimmune Disease Treatment Center, which has become internationally recognized for its role in the development of new therapies for lupus. For 20 years, he served on many communities of the ACR, and he was named Master of the College in 2018. He is currently an Associate Editor of Arthritis and Rheumatology. Although often featured as a speaker at national and international conferences, Dr. Furie's favorite educational venue is at home with his colleagues and trainees. He will discuss systemic lupus today with a focus on clinical aspects of the disease, along with a review of pathogenesis, classification criteria, and disease activity measures. He will conclude with a description of some of the recent treatment advances. Thank you.
Thank you for the introduction. All right, I assume that technology is working, and I can even advance my slides. Here are my disclosures. All right, this is not audience response, but who is this famous dog? Is it Lassie, Rin Tin Tin, Toto, or Millie? All right, here's a hint. Who is that lady on the right? So the answer is Millie. All right, next question. What condition did this dog, this famous dog, have? Was it lupus by chance? Well, it sure was. So here's the connection. So when I was at your stage, my division chief, Charles Christian, who is known for lupus, and so we are going back to the early 1980s, was called by George Bush to come down to the White House. Why? Well, it was known that Mrs. Bush had autoimmune thyroid disease, and then the dog developed lupus. So they wanted a consult regarding autoimmunity at the White House. But he was not asked to come see Mrs. Bush. He was asked to go evaluate the dog. And that is a true story. So he went down there and evaluated Millie. All right, here are some of the references that you can look up and read. And as mentioned, this is what we'll cover today in the next hour. All right, let's start with the clinical heterogeneity. There's absolutely no disease more heterogeneous than lupus. And this collage, and I could actually go on for many slides, demonstrates the various rashes, Raynaud's, central nervous system involvement. And I even put in for Brad an immunofluorescence of the kidney. We see livedo reticularis, paniculitis in lupus in the bottom left, heart valve problems. There is no organ that has not been affected by lupus. It makes it incredibly challenging, very interesting. So it is the prototypic autoimmune disease. Not only is it heterogeneous as far as the manifestations, the disease activity is quite variable. And for the typical patient, there's a chronic waxing and waning course. And as you well know, females outnumber males 10 to 1. And it's more common and also more severe in African Americans, Hispanics, and Asians. So what is the basis for heterogeneity? Well, it comes down to genetics, epigenetics, and as you'll see in a little bit, pathogenetic mechanisms are quite different. Different pathways are activated in different patients, different autoantibodies appear in different patients. Demographics clearly play a role, and I did mention ethnicity and race just a few seconds ago, but also socioeconomic factors play a role. And this makes it incredibly challenging. So prognostication is difficult, except we know if a young African-American female walks through the door, has DNA antibodies and proteinuria, that patient is going to have a difficult course. Not that we have a lot of drugs in our toolbox, but that will increase. So this heterogeneity makes it a little difficult to select drugs, but it certainly has made it challenging to design clinical trials and to develop drugs for lupus. A very busy slide, and I don't expect you to memorize all these numbers, but this just speaks to the epidemiology of lupus in the United States. In prior years, we were told there are 2 million people with lupus in the United States. Well, that's way too high. There were 2 studies done and published at the same time. Emily Summers from Michigan published one, and Sam Lim, the other, Sam being down at Emory. So they looked at their areas, Detroit and Atlanta, and came up with very similar numbers as far as the incidence and prevalence of lupus. And you see in the second line of both incidence and prevalence, comparisons to rheumatoid arthritis and scleroderma. And then very recently published by Pete Ismerli was the prevalence of SLE in the United States. And these are patients who met classification criteria, which I'll go into in just a bit. So a little over 200,000 people in the United States meet classification criteria. As far as mortality rates, they're 5 times greater in males, even though females outnumber males. The males are sick. The other sick population, or really sick population with lupus, are the kids. And I learned that from our pediatric rheumatology folks here at Northwell, because we inherit their patients. We have had some recent highlights over the last 2 decades as far as drug development. Our toolbox was kind of small. It's growing in number, but nothing like what we've seen in rheumatoid arthritis and nothing like we've seen in psoriatic arthritis. I think the use of mycophenolate has been a major highlight, and it goes back to some of what Brad spoke about. And those were the early studies out of China by Dan Chan comparing mycophenolate to cyclophosphamide. I've listed the complete response rates on the right-hand side of the slide, and you see they are comparable between mycophenolate and cyclophosphamide. And that led to the study by Ellen Ginsler, also looking at not only proliferative nephritis, but also included pure membranous, and showing numerical superiority of mycophenolate over cyclophosphamide. And then Jerry Appel was the lead author on the ALMS trial, which was a global trial also looking at proliferative and/or membranous nephropathy. What's so striking is not so much the similarities across rows, but if you look at columns, very different response rates in these different studies. A story for another day. And then we had the comparison between mycophenolate and azathioprine in the maintenance phase of the ALMS trial, showing that mycophenolate, using a different endpoint, using a composite endpoint, was superior to azathioprine. Then in 2011, we had our first drug approved via the route of a randomized controlled trial, and that was of belimumab based upon the BLISS 52 and the BLISS 76 trial. And hydroxychloroquine. I mean, this is an old drug. Its predecessor, chloroquine, goes back to World War II. But it's now dogma that everybody with lupus be on hydroxychloroquine. It used to be that we'd limit it to rash and arthritis, but studies have shown increased survival, reduced lipid levels, antithrombotic effects, reductions in damage, and flare prevention. So everybody should be on hydroxychloroquine. Are they all on hydroxychloroquine? No. I was embarrassed by a talk someone from Bristol Myers who we're collaborating with and provided a lot of samples. And it turns out that only about 2/3 of my patients were on hydroxychloroquine. And it's yet another story, what percentage of your patients take hydroxychloroquine? They allege that they're taking it, but if you look at blood levels, which are now available, I'm finding a fairly high percentage of patients who come back with blood levels of 0. And this is nothing new. This was described to us by Natalie Costa-Doed in Paris, but now we have available this blood test. The mechanism of action we never quite understood, but now we do, especially with the interferon pathway becoming very popular. And essentially what we see is that it increases the pH of the lysosome, and that inhibits toll-like receptor signaling, and the net result is a reduction in production of interferons and TNF by plasmacytoid dendritic cells. And I'll go into this in a little more detail. Brad mentioned the voclosporin phase 3 trial called Aurora. So a success. In fact, we had something amazing that we'll never see again, and that was 2 drug approvals for lupus nephritis in back-to-back months, belimumab in December and voclosporin in January. These are the top-line results, which he discussed, as well as the BLISS-LN trial, which led to the approval of belimumab for lupus nephritis in December. All right, let's go into disease pathogenesis. You'll hear about monogenic lupus. And examples would be people with complete complement deficiencies or the interferonopathies. But I must say that monogenic lupus is pretty uncommon. And when we talk about polygenic lupus, we're really talking about susceptibility genes lining up in a network that confer increased susceptibility to lupus. Now here are some of the genes that have been described in monogenic lupus. And for example, if you look at complement deficiencies, and you see very high percentages of patients with C2 or C1q deficiency developing lupus. And interferon is very hot these days in lupus, and there are the interferonopathies like TREX1, and there are several others as well. When we talk about polygenic lupus, here are, I think there are around 83 loci described in this paper from 2017, and I'm sure in the last 4 years, there are a lot more described. But what's interesting is that these polymorphisms are found in pathways that are very important for immunology and for lupus. And I'm not going to read through all these, but you can certainly read through them yourself. Now, another way you may see the gene abnormalities displayed is with a Manhattan plot. And you see that here, a lot of activity, chromosome 6 with HLA genes, as well as some of the complement genes. But it's not just about the genes. In fact, if you look at identical twins, there's about a 25% concordance rate for the development of lupus. So that means something else must be happening. So there's clearly epigenetic influences, And we've been talking about environmental factors. What's been implicated over the last 40 or 50 years? Viruses. A lot of work has been done on Epstein-Barr virus. Smoking is implicated. Ultraviolet light. In fact, I learned my lesson about ultraviolet light and lupus, telling stories going back to Hospital for Special Surgery, where I was a fellow. But prior to that, I was a resident at New York Hospital. And I thought an easy way to start my junior residency year was a rotation through HSS. What do you do there? You would admit patients with rheumatoid arthritis for pool therapy, and then you go home. Well, I learned my lesson about ultraviolet light that July, because the first 2 times I was on, 5 patients with lupus got admitted, and 3 out of the 5 were really sick, and I had to transfer in the middle of the night to the intensive care unit over at New York Hospital. So you will see not only exacerbations of skin disease come August and September, but you will see other manifestations as well. Sex hormones, we know drugs can cause drug-induced lupus. There's literature about diet, there's literature about unhealthy lifestyles. But the bottom line is we don't know. But when I explain this to patients, I say, it's not like brown eyes or blue eyes. There are susceptibility genes, but it goes beyond susceptibility genes. There's some type of environmental trigger which we have not identified. This is an iconic figure. This is from the New England Journal of Medicine, almost 20 years ago. And the bottom line is that autoantibodies precede clinical manifestations of lupus by many years. And the way they did this study is they took Army recruits with lupus and they dug back into the serum bank held by the Army. And what they saw was the development of autoantibodies long before they developed their lupus. So there's a preclinical immune abnormality, and then at some point along the line, patients will develop manifestations of lupus. So talking about these antibodies, how do they induce injury in lupus? Well, here are 4 different models. On the far left, direct binding. So a pathogenic antibody can bind its target and cause abnormalities in that particular cell. And many think this is the cause of central nervous system dysfunction in some patients. It may lead to apoptosis of certain cell types. The second column is the classic one. It's the formation of immune complexes. The antibody against DNA, and those little squiggles is my version of DNA. So you have this immune complex, lodges in the kidney, it activates the complement pathway and attracts various cell types in, including neutrophils, which can damage the kidney. The third column is ADCC, antibody-dependent cytotoxicity. And the model here is of autoimmune thrombocytopenia, autoimmune hemolytic anemia. And in this model, the antibody binds its target, in this case, a platelet, and the Fc of the antibody is sticking out and can be bound to the Fc receptor on a phagocyte. And this complex will be engulfed by that phagocytic cell. And the last column is CDCC, complement-dependent cytotoxicity. And the model I have here is autoimmune hemolytic anemia of the cold type, where the antibody binds to the surface of the red cell, it comes off in the warm, and when it does so, it fixes complement to the red cell surface. And there are complement receptors on various phagocytic cells. So that is yet another mechanism for antibody-induced injury. Then, of course, there are many cell types in lupus that are implicated. And pick your favorite one or ones, and there are many that I've left off this list. Then we have various inflammatory mediators, and this is just a short list. Interferons right now are hot. We have B lymphocyte stimulator. That's the target for belimumab. And a whole slew of others. And I think we need to pay a little more attention to complement as far as a therapeutic for our lupus patients. And then there's the vasculature. We see microvascular thrombosis. We see macrovascular thrombosis. I think Brad mentioned a biopsy with thrombotic microangiopathy. We see a lot of this in our lupus patients. Our first description was back in the early 1990s of 7 cases of our lupus patients with thrombotic microangiopathy. All right, now for a review of my rendition of the pathogenesis of lupus. But before we get to that, let me just remind you that the immune system can be divided into the innate immune system and the adaptive immune system. The innate immune system is ancient. In fact, it's found in all plant and animal life. The responses are not the least bit sophisticated. They're found to be immediate, not sustained, and examples would be neutrophils and toll-like receptors and complement. So they're kind of old-fashioned. But if you look at the right-hand side, I show the characteristics of the adaptive immune system, which is evolutionarily advanced, found in vertebrates only. The responses are antigen-specific, and the responses get stronger and stronger through somatic mutations. Examples would be lymphocytes and antibodies, but there's clearly crosstalk between the two. So with that as background, let me show you my rather simplistic rendition of the pathogenesis of lupus. I have components of the innate immune system in the top right and the adaptive immune system on the bottom left. So we take the genetically susceptible host exposed to an environmental trigger. Here it's the sun beaming down on the skin of a lupus patient, causing apoptosis of skin cells and the release of nucleic acids, RNA and DNA, which can form immune complexes and can enter into the plasmacytoid dendritic cell, which are very abundant in the skin of lupus patients. And these cells are mass producers of interferons. DNA and RNA activate toll-like receptors 9 and 7, respectively, and that results in the production of a lot of different inflammatory mediators, chief of which are the type 1 interferons. We'll cross over to the activation of the T cell by a myeloid dendritic cell. And there are a lot of different molecules that have been, are, or will be targeted for drug development strategies in lupus. And I'll show you some of them at the end. The T cell and the B cell interact via the T cell receptor and the MHC, but there are several co-stimulatory molecules that are required for full activation. The B cell is dependent upon 2 key mediators, APRIL and BLyS, B lymphocyte stimulator, which again is the target for belimumab. The fate of the B cell is that it can mature into a B memory cell or into a plasma cell, and both B cells and plasma cells spew out antibodies, and in the case of lupus, autoantibodies. And here you have an immune complex forming. This is an antibody to DNA, complexing with DNA, which activates the complement pathway, in turn attracts neutrophils, which cause tissue injury, and then we have the activation of the macrophage. That's my rendition of a DNA net. And this can all start over again with these immune complexes entering the PDC via the FC receptor on the plasmacytoid dendritic cell. And the DNA net can also activate the PDC. All right, now we will move on to classification criteria and disease activity. There are now 4 SLE classification criteria, with the most recent one being a project of EULAR and ACR. And here it is. The writing might be a little bit microscopic, but the gist of it is, in order to be classified as lupus, one has to have a positive ANA or a history of a positive ANA of 1 to 80 or greater on a conventional cell line, such as the HEP2 cells, which is a human laryngeal carcinoma cell line. And then what you do is you look at these various boxes, and you need to have a total of 10 points. So based on clinical manifestations on the left-hand side and then you see immunology domains on the right-hand side. But you had to have at least one clinical domain. And you score the highest scoring item in each of the boxes. And if that adds up to 10 or more, you can classify as that patient as having lupus. Now, this is a very important point. Classification criteria are not diagnostic criteria. Diagnosis of lupus is in the eye of the beholder. So you can call a patient lupus if you so desire. But in order for that patient to enter a clinical trial or any kind of clinical research study, they have to meet classification criteria. So this is a very important point. In fact, there are no diagnostic criteria for lupus. We often take the classification criteria and use those in explaining to a patient why they have or do not have lupus. All right, now you might think I've gone crazy. Some of you who are listening live out near these deserts. There are 4 major deserts of the United States. So what do these deserts and lupus disease activity instruments have in common? Well, again, it's not audience response, but they're very dry, all right? So I'm going to explain to you some of the disease activity instruments. And it's really tough to read about these things personally, though I do a lot of clinical trials and I need to read about these things, but they can be kind of dry, but you need to understand them if you're going to interpret clinical trial results. So we'll spend a few minutes on this topic. Well, I'll be the first to admit, I don't use the SLEDAI when I see patients. I see about 40 or 50 lupus patients every week, and I use the Gestalt method, very informal, mild, moderate, and severe. In fact, I don't even write that in the chart. I keep that in my head. But there are formal disease activity instruments. The 2 that have risen to the top are the SLEDAI, which came out of Toronto, and the BILAG, which came out of the British Isles. And then we've made life even more complicated. We've made composite indices, which I'll show you. One is called the SRI, which stands for the SLE Responder Index, and the other the BICLA, the BILAG-based Composite Lupus Assessment. The SLEDAI evaluates 24 lupus manifestations, and you score a parameter not only if it's present, but if it's attributed to active lupus. If the patient has a scarred discoid lupus rash that's not active, you don't check off rash. That's damage, it's not active. So I have that highlighted in yellow. It has to be attributed to active lupus. And each item is scored, ranging from a low score of 1 to a high of 8. And you might not agree with the scoring. So for example, thrombocytopenia could be life-threatening, gets 1 point, whereas arthritis could be very mild, it gets 4 points. But be that as it may, the scores are totaled, you get a total score, and I've listed some of the guidelines for equating disease activity with severity. In order to lose points, there has to be complete elimination of the manifestation or resolution of the laboratory abnormality. If someone has head-to-toe discoid lupus and they go into a clinical trial and they get 95% better, I mean, it's amazing their response, but they still have a little active discoid lupus, you still unfortunately have to check that off and they still get their 2 points for rash. And we think that somewhere between a 3 and 7 point reduction in the total SLEDAI score is clinically meaningful. Now there's the BILAG from the British Isles. And it's the same principle, a little more complicated, a little more cumbersome, but it measures improvement or worsening by organ system domain, and there are 9 domains. And it compares it to the prior month. There are roughly about 100 different parameters, and you basically score the item as not present, improving, same, worse, or new. And then each domain, each of the 9 domains gets a letter score, based upon a detailed set of rules, which I cannot keep in my head. So I keep the little BILAG Bible next to my desk when I'm working on a clinical research project. But the short of it is that if someone has an A score, that's severe disease activity, whereas E is not only no activity, it means they never had that domain active during the history of their lupus. As I mentioned, we've made life more complicated, and we now have composite indices, which have become endpoints for clinical trials. The SRI, the BICLA, and a modified SRI. The SRI grew out of the belimumab program. The phase 2 study was a failed study, but there were signals, and to move this forward, we needed a clever way. And the SRI grew out of a post hoc analysis of the failed phase 2 study. It was a dichotomous responder index, which was very appealing. So people would be declared either a responder or a non-responder. And to be considered a responder, one had to have a 4-point or greater improvement in the SLEDAI score, but they couldn't get worse. And that was a very important point. I do remember one of our patients in yet another study who had a remarkable skin response, but during the study developed nephritis. So you could not call that person a success. Therefore, efficacy was driven by a reduction in the SLEDAI score, but they could not get worse by either BILAG or physician global assessment. So very important to emphasize that all three of these items have to be met in order for someone to be declared an SRI responder. And then there's the BICLA, which is sort of similar in concept to the SRI, but the BILAG was the driver of efficacy. And this was the primary endpoint for a phase 3 program with a drug called eprotuzumab. And we typically see concordance between the SRI and the BICLA, but not always. There have been some recent studies where we did not see concordance, and we're trying to figure that out. And here are the components of the BILAG of the BICLA. As I mentioned, BILAG is the driver of efficacy. All BILAG A scores, so that's the worst domain score, have to go down to B or less, and Bs have to go to C or less. And there can be no worsening by BILAG, by SLEDAI, or by physician global assessment. And obviously in all these studies, if you receive some kind of treatment that's not allowed, you are considered a failure. We rely on other instruments in our lupus clinical trials. So for organ-specific activity, we use the CLASI for skin and joint counts, just like in rheumatoid arthritis, to measure arthritis activity. We look at flare activity. We see how the patient views how they are doing with a patient global assessment. Quality of life, there are many different quality of life measurements, but the SF-36 is a popular one, as is the FACIT fatigue scale. And then we collect organ damage information, though in a 1-year trial, we don't see too many people accrue damage. Now you will hear more and more about a couple of other programs and projects to look at endpoints. There's lupus low disease activity, which came out of the Asia Pacific group, and they're characterizing a state. So I'm not sure who developed this particular statement, but I really like it. So they say it's good to be better, but better to be good. So this is a state of goodness that's achieved. And you see the definitions on this slide. One has to have a SLEDAI score of less than or equal to 4. So we're not talking about a reduction by 4 or greater. We're talking about an absolute number that's 4 or less. And there can be no new lupus disease activity. You can see definitions for the PGA, and the prednisone dose has to be less than or equal to 7.5. And in fact, it's been shown if one achieves this state, that one accrues less damage than if one does not achieve this state. Another program is the DORIS program. And this is a group heavily based in Europe that has come up with definitions of remission. So it's great that we're finally talking about remission in lupus. A little easier said than done, however. And you see 4 different definitions. So it gets a little complicated. Do they have to be on medicines? Can they be off medicines? What about serologies? So this is still being refined. What we do know is that not too many patients actually enter into a strict remission. All right, and then in the last several minutes, we'll talk about current and future treatments. I know this sounds very trite, but the basics of therapy in lupus: do good, do no harm. And what do I mean by do good? Control disease activity, prevent flares, prevent damage from the disease, and reduce the development of comorbidities. We deal with a lot of comorbidities in lupus. And do no harm, so prevent damage from treatment, especially from steroids. And it drives me crazy. I've been battling the emergency room physicians for about 40 years here at North Shore, Northwell. A patient might could go into the emergency room with mild, minor arthritis. And what happens? They have an IV stuck in them and they get 120 milligrams of methylprednisolone. It's not necessary. They don't see the long-term side effects of steroids. You will. You're at the early stages of your career, but just follow a patient with lupus, or for that matter, vasculitis, over a period of time, and you will see osteoporosis and osteonecrosis and skin fragility, and I can go on, cardiovascular risk. And it's very important. I made the distinction between activity and damage when talking about the SLEDAI. Do not treat damage with agents intended for active disease. So that discoid lupus patient who just has damaged skin, you can bombard that patient with the most miraculous drug. You're not going to reverse the damage. The definition of damage is that it's irreversible. So save your treatments for active disease. This is our toolbox right now. Those in yellow are FDA-approved therapies. But nearly all of the FDA-approved therapies were grandfathered in back in the 1950s. The 2 new ones are belimumab in 2011 for SLE, and 2020 for lupus nephritis, and then voclosporin in 2021. And then we use what I call adjunctive therapies. The ACE inhibitors, the bisphosphonates. You should watch the patient's lipids. For really bad discoid lupus, I like thalidomide, but not everybody does because it can create many adverse effects. All right, a little bit of talk about damage. Activity begets damage. This was a study published last year by the Toronto group. They've had a cohort for many decades, and I'm going to focus on 3 different things: on the baseline SLEDAI score, the baseline prednisone, and the baseline damage score. These are patients who entered into their cohort and had SLEDAI scores of 6 or greater. And then if you look at the right-hand side, the percentage of patients who accrued more damage at 1 year and at 5 years. And you can see a dose response with SLEDAI scores. The more activity they had at entry, the more likely they were to develop damage down the line. The same with prednisone. The greater the prednisone dose, the more likely they develop damage. And if they came in with damage, they were more likely to develop yet more damage. So activity begets damage, damage begets more damage, and damage begets mortality. And this is a study that was published recently, a meta-analysis showing the results of several different studies. And the bottom line is that there was a 34% increased risk of death for each 1 point increase in the damage score. And as mentioned, we deal a lot with morbidities, and you can see them listed here. The big one being renal disease, as Brad Rovin taught us. But osteoporosis, there's an increased cancer risk. Infection is a big problem. I can't tell you how many of my patients have had strokes. And cardiovascular disease is responsible for mortality later along the course of their disease. All right, this is not audience response, but you can take a guess. In 1950, the outlook for patient with lupus was terrible. 7-year survival was about 50%. Can you imagine being 22 years old and knowing that you have a 50% chance of living 7 years? This was back in the 50s. But in the modern era, with the state-of-the-art therapies that I showed you, what do you think the mortality rate is now? Well, I'd love to be able to tell you that it's close to 0, but it's not. It's about 15%. And this was shown in an article from the Annals of Internal Medicine. We do see a reduction in the age standardized mortality rate in lupus for the last 20 years. If you look at the circled area, that's minus 2.7, but it's not as steep a decline compared to those age-adjusted mortality rates in patients who did not have lupus. So we are still dealing with a mortality rate that's in the teens. And what's interesting, if you look at the fourth bullet down, of those aged 15 to 24 years old, SLE as a cause of death ranked 10th, 5th among Black and Hispanic females, and ranked 1st among chronic inflammatory disease. And Brad talked about the morbidity associated with lupus nephritis. I mean, still 40% of our patients with diffuse proliferative disease will develop end-stage kidney disease at 15 years. So how are we performing now? Well, it's hard to get a handle on this, but the way I tried to answer this is I looked at a whole lot of studies that we've recently completed. And these are the SLE studies I'll show you on the next slide, the lupus nephritis trials. This is the endpoint, and obviously the more rigorous the endpoint, the lower the response rate. But what you see in the far right is the response rate in the placebo arm. And in all of our clinical trials, placebo is not just placebo. Placebo is standard of care. These patients are coming in on their background therapies, their steroids, their antimalarials, their immunosuppressives. But what's so striking is that you don't see a response rate much over 45%. So that means the majority of our patients are failing to achieve one of these endpoints. It gets worse for lupus nephritis. Same table design. The drugs on the far left, the endpoint, which is generally a complete response driven by reduction in proteinuria. And if you look at the far right, again, this is the standard of care arm, which for most of these studies was mycophenolate and steroids. So the clear majority are not achieving a complete response. And what we do know is that those who do best long-term are those who do best short-term. So we have major unmet needs, lupus nephritis, severe extrarenal disease. We need to prevent damage, either from the disease itself or from the medicines we use to treat the disease. On the list is remission induction, and we can't forget about the patient. We need to improve their quality of life. So we'll finish with some novel therapies in development, just speaking in generalities. Let's go back to 1979. Where were all of you in 1979? Well, I had just graduated from Cornell Medical School, and in July I was starting my internship. That was a rude awakening from having a nice relaxed schedule, sort of relaxed schedule, to then being on 80 hours a week or more, especially during the summer. But anyway, so this group at the NIH surveyed lupus patients. Actually, they surveyed a variety of rheumatic disease patients, and they measured interferon in their blood. And their conclusion was, it is possible that the production of interferon may contribute to immunologic aberrations in autoimmune diseases. All right, so back to my cartoon. If we focus on the early events in the innate pathway, the production of type 1 interferons is key. And there are several different ways to target type 1 interferons. In fact, you hopefully will hear this summer about the FDA's decision on a drug called anifrolumab, which is an antibody to the type 1 interferon receptor. And basically, when that drug is administered, we see an inhibition of the interferon gene signature. And I wish I had another hour, I could go into much greater detail. Another potential target is the B cell. And there are a lot of different proteins on the B cell that can be targeted. But as risen to the top is CD20. And Brad talked about rituximab, he talked about obinutuzumab. Those are monoclonal antibodies that deplete B cells by targeting CD20. There's an interesting program with inhibitors, or I really should say, a drug that facilitates the degradation of these nuclear transcription factors, Ikaros and Aiolos, and that's moving to phase 3. We did not have good luck with BTK inhibitors in a couple of SLE trials. Then we can target extracellular proteins. And I did mention BLyS and APRIL. APRIL sort of a companion to BLyS. And there are different strategies for inhibiting BLyS. BLyS and APRIL bind key receptors on the B cell, BLyS receptor, TACI, and BCMA. And this monoclonal antibody is belimumab. But also in development is a recombinant TACI receptor that binds both BLyS and APRIL. Then we're getting like oncologists and targeting long-lived plasma cells. So it's interesting biology. If one gives a drug like obinutuzumab or rituximab, you deplete B cells, and you'll see a reduction in antibodies, such as anti-DNA antibodies, but we do not see reductions in the RNA antibodies like Smith, RNP antibodies, SSA and SSB, and that's presumably because those antibodies are made by long-lived plasma cells, which don't bear CD20 and therefore are not subject to the effects of a B cell depleting agent, such as rituximab. So we can target plasma cells, and there are different strategies. APRIL will target BCMA. We are investigating proteasome inhibitors, and then antibodies to CD38, and these are ways to target the plasma cell. T cells play an important role, and there are a lot of potential targets on T cells. So we can target the T cell itself, or we can interfere with T-B cell interactions. And there are a lot of pairs here that can be interfered with. In development right now, antibodies to CD40 ligand, antibody to CD40, antibody to ICOS ligand. We are looking at actually not inhibiting interleukin-2, but providing interleukin-2 to patients with lupus, because on average, lupus patients are deficient in their IL-2 production, and IL-2 is important for the production of T regulatory cells. So a lot of different strategies. And there are cytokine targets. I mentioned IL-2 restoration. And actually sometime this year, we will hear about the phase 3 baricitinib trial in SLE, and that targets the JAK pathway. So I am very optimistic about the future. We've come a ways, and we have a long ways to go, but we will get there. We will have more medicines. We will have biomarkers. And I think eventually we'll have individual therapy for our lupus patients. And what this translates into is better outcomes for our patients with lupus. Now, I don't know if this is going to work. I finally figured out on Zoom how to show video clips, at least get the audio working. And I could give it a try if there's someone on the call that knows how to do this. But I will activate.
Antibodies down. ANA anti-Smith for lupus, rheumatoid factor, rheumatoid arthritis, there's anti-centromere. We're looking for the double-stranded DNA in lupus nephritis. Anti-SSA, anti-SSB, other antibodies for Sjogren's disease, anti-LP for MCTD, anti-basement membrane for good muscle disease. Anti-Go1 for polymyositis. Anchor can be found in microscopic polyarthritis, anti-GAD, diabetes mellitus, and anti-smooth muscles in autoimmune hepatitis, anti-mitochondrial PVC in celiac spirus for anti-TPG, anti-histamine in scleroderma SCL17. Let's say that a patient has a bikini anti-coagulation antibody as long as they're looking for hypokalemia and lupus proteoglycans and aflatoxin. Yes, dies in Graves' disease. Now let's say your patient has a high MCV, pernicious leukemia. It's maybe an anti-varietal cell antibody. Anti-TPO, Hashimoto-thyroiditis, osteochondritis, gravis, finally, anti-tryptic antibody is not used to diagnose ITP. That's all the antibodies for now.
All right. So thank you for listening. And I don't know, could you hear the audio on that video?
Yes, we could. Thank you, Dr. Furie, for your talk and that funny video. We have a few questions that we have, so I'll just get right into it. So introduce myself. My name is Ronak Patel. I'm one of the second-year rheumatology fellows at Ochsner in New Orleans. First question. We do know that you mentioned that the classification criteria are not diagnostic. Is there any one set of criteria that you find useful for fellows or clinicians to use to identify patients with lupus?
I think you'll find similarities. There are obviously more similarities than differences between all 4 classification criteria. So again, when you're with a patient, it's really up to you. And I find it difficult often when a patient comes in who's been told they have lupus and they really don't. I actually confront that kind of situation more often than making a diagnosis of lupus. What we find around here is that there are a lot of referrals for positive ANAs with kind of soft symptoms. So you can resort to the classification criteria to reinforce to that patient that actually they don't have lupus, but you're kind of on your own to generate the verbiage that you want to use in explaining these various scenarios to patients.
Thank you, Dr. Furie. Yeah, that's actually very challenging because oftentimes we end up with this undifferentiated connective tissue disease and more of myalgias, arthralgias, and we don't have objective findings. So that's really important for us to relay to our colleagues as well, and to make sure we're not overdiagnosing lupus.
Yeah, so a few points about that. I really hate that term, undifferentiated connective tissue disease, because I think most people use it just to write down an ICD code so they can bill. But there is true MCTD, mixed connective tissue disease, described by Gordon Sharp many decades ago. And it was a true overlap of lupus, myositis, and scleroderma with high titered RMP antibodies. So sometimes those two get interchanged.
Right, and then even that sometimes just gets overdiagnosed with just an RNP antibody, right?
Yeah, the other
MCTD.
thing to discuss related to this is the patient who has the ANA. Well, we know ANAs are a dime a dozen. I think it's estimated 30 to 40 million healthy people in the US would test positive for ANA. But a small percentage will go on to develop lupus, and is there a way to figure out who that is? Ed Vitale in England, up in Leeds, has coupled that with looking at the interferon signature. I think that the interferon signature coupled with the positive ANA may be more predictive of someone who transitions to lupus. There's a study being done in the United States right now, actually, to see if hydroxychloroquine will head off the development of lupus in these patients with what's called incomplete lupus.
Good to know. Thank you. Another question we have for you is, do you foresee increasing need for disease activity use and documentation in clinical practice as the armamentarium of drugs for lupus expands? So insurance companies have already started asking for documentation of disease activity to authorize some of the newer drugs. So what's your take on that?
Yeah, that's a very good question. I guess I always liked rheumatology because there were no algorithms. But now we're seeing more and more algorithms and gatekeepers. And a lot of it does have to do with the expense of drugs. So lupus was not on the radar of insurance companies for the longest time. But now with belimumab and voclosporin, it is. So around our area in New York, they're not uniformly asking for SLEDAI scores, but I certainly have it on our authorization request forms that the clinician put down what the SLEDAI score is. It sometimes means doing extra tests. I mean, obviously we should be checking urines on patients, but you may not have to get that every time, but you need that for a SLEDAI score. And you know, the SLEDAI doesn't tell all. I mean, one of the problems with the SLEDAI is that, for example, you could have the worst discoid rash, severely active discoid rash, and nothing else, no serologies that are on the SLEDAI, and still just get 2 points. But that doesn't mean that patient is not in need of some, novel therapy. So we need to educate the people who are overseeing the approval of our drugs. And I mean, at the insurance company level.
The next question we have is, how do you make treatment decisions in lupus patients in regards to their symptoms, especially comparing the conventional DMARDs versus the newer therapies like belimumab?
That's a pretty general question. Unless they just want to know, do I move to a immunosuppressive or a biologic first? Yeah, that point is a very interesting point, and I think deserves some research. And I think it also depends on the manifestation. So for someone who has arthritis despite being on hydroxychloroquine, I probably would move to an immunosuppressive before a biologic. For someone who has rash, that's a good question. For someone who has lupus nephritis, they're probably going to get both. So it really depends upon the manifestation. And there's not been a head-to-head comparison or head-to-head study looking at those first-line failures and seeing whether they should get a biologic or whether they should get an immunosuppressive. We have to remember in these clinical trials in lupus, take the BLISS study, the BLISS 76 phase 3 belimumab trial. About half of the patients who entered the trial were on background immunosuppressives. So I think we will all have to develop an experience, and rheumatologists are very good observers of outcomes.
Thank you. I have one more question, kind of on that same treatment realm, but with these two new medications that we have from December and January for lupus nephritis, how does one decide between starting one over the other? And I'm speaking specifically about voclosporin and belimumab.
So Brad didn't answer that. Well, the first order of business, in fact, I'm debating Brad on that topic at PANLAR in a few weeks. All right, but the first order of business is, for someone with proliferative nephritis, let's not talk about membranous, pure membranous, because that's a tricky business. But for proliferative nephritis, does one stick with standard of care, meaning mycophenolate alone or say cyclophosphamide alone, or does one use combination therapy with MMF or voclosporin? So I was the organizer, a co-organizer of the Lupus Academy this past, when did we have that, in June? And arranged for a debate between a nephrologist and a rheumatologist on that topic. And I didn't think the rheumatologist, Dimitri Bumpus from Athens, had a chance because he took the side, just monotherapy was adequate. Whereas Anno Teng, a nephrologist from the Netherlands, took combination therapy. But Dimitri made a lot of good points about just sticking with standard of care. And I don't really have time to go into that. Personally, I think the data for both voclosporin and belimumab show an increased effect size without added safety problems. So, you know, barring the economics, I would go with combination. Now, which one does one choose between? That is very difficult. And I don't think anybody really knows right now. And you can't just go by the effect size being a little greater for voclosporin, 18 percentage points versus 11 for belimumab. Two different trial designs, two different populations. The belimumab study was 2 years long. And when someone drops out of the study, even if they're doing well, they're considered a non-responder. So that hurts your numbers. So the bottom line is we don't know. There's growing evidence with belimumab that it may prevent damage accrual over time. And actually Brad presented those data at the ASN meeting last fall. So time will tell. And then I hear from others, if someone has massive amounts of proteinuria with a big membranous component, maybe the calcineurin inhibitor is the way to go. So what we need is a head-to-head study, or maybe just combination therapy with 3 drugs, MMF, a CNI, and belimumab, because we still have a ways to go, and I think Brad pointed it out. We're still, with our best response rates in proliferative nephritis, still under 50%. Now, we don't know what the ceiling is, but we're under 50%.
Thank you so much. Okay, I think that concludes our morning session. So thank you again, Dr. Furie, for an excellent talk, and thank you also to Dr. Rovin earlier this morning. Just a reminder to all of our attendees, the recording of this session will be posted to the VIP adult website within 24 hours. And the next adult session will be on large and small vessel vasculitis on Thursday, July 22nd at 10:30 a.m. Eastern Time. Stay tuned, and thank you to everyone.
Bye.